How's it going, guys? This is Dr. David Johnson.
And PT Nandi here.
Nandi.
Aloha. It is Friday.
Yeah, Aloha Friday with SHARC Doc Talk. Doc T's busy with his stuff that he has to take care of today. Yeah, so we decided to go do a podcast ourselves.
Here we are.
So
here we are.
Here we are doing it.
Outside the koi pond.
Oh, yeah. I like to call this the Shark Tank.
The Shark Tank.
Kind of out here.
Yeah, definitely.
In the gym floor area.
Windows all around.
Windows all around. Can't tap on the glass while we're cheating.
I know, right? Hello.
But yeah, so that's where we are today. I think you guys have kind of said that you guys like this view a little bit more, so we're
awesome.
We're keeping it. The hard part, though, is that we have to film after patients or before patients.
Sure, exactly. That is the challenging part. We cannot be sequestered in the office anymore.
Yeah. So when you saw us doing it in the office, it's because it was a busy floor.
Yeah.
So we wanted to make it look a little nicer. So basically, thanks for the input, guys. But today, before we even go on to our topic here, how was your week?
How was my week? My week was good. It's always, I remember sitting at a treatment table on Tuesday thinking, God, it's Tuesday. Why can't it be Thursday or Friday? Friday. So it's Friday. My week was good, kind of busy. Mm-hmm. Nothing too out of the ordinary, but leading into our topic, I have a patient who is I think she's a chemical engineer student.
Oh, that's cool.
Yeah, she's very cool. She wants to work in F1. And,
that's really cool.
And she has knee pain,
mm-hmm.
medial knee pain, but possibly positive for meniscus, but just some overall valgus, internal rotation instability, and recently had an MRI to
mm-hmm.
rule anything out, and everything was negative. So her knee pain just persists at the end of deep knee flexion. So that's been fun, just treating her. She's willing to do everything I ask her to do. She just apparently just needs to be stronger, and it's just a matter of kind of getting her there. But she's a student, so she sits a lot.
Yep.
And doesn't do a ton of extra muscles, extra like resistance strengthening at
mm-hmm.
home. Probably does just the normal exercises that we ask her to do, which is fine.
Mm-hmm.
But biomechanically and kind of genetically probably predisposed to not being the best muscle builder. So, and with, being a chemical engineer student studies a lot.
Yeah.
So, you get those people that sit a lot and study a lot, and just for their jobs to sit and
mm-hmm.
kind of outweighs the amount of exercise that they can do.
Yeah.
So it's a little slow going.
Yeah.
But other than that, nothing truly out of the ordinary. I would say had an interesting total knee patient with a total knee. Had some posterior knee pain that could have been
something.
Could have been like a. She said she felt a pop.
Okay, so it could be multiple things.
Yeah, but it was only like 2 weeks post-op, and I'm like, well, scar tissue can form, but does it form that quickly? And if it does, could it be something like that?
And before you go on, just for everyone at home, when we say total knee, we're talking about total knee replacement.
Yes, total knee replacement, and was fine, had a little bit of extra swelling, but nothing crazy. And I would say with could have been just maybe scar tissue. I don't know, but it did go.
Could be something.
Yeah, it did eventually go away. So that was good. And she's walking a lot better than she was when she first started with therapy, and even after that kind of incident when it came up.
Oh, that's fantastic.
Yeah,
that's fantastic.
But that seems to be my week. Nothing crazy. My student's doing really well. Good. She's on her last week this coming up week, and
that's huge.
As her first clinical experience, she is now where she needs to be for her curriculum, which is about 50% of my caseload. So that helps for her, and she's super intuitive. Everybody likes her, and she's doing really well. So
that's good.
We'll send her off next week. She gets to do a gets to do an in-service, and she's going to do it on a new type of. Hold on 1 second. Let's calm that down. There we go. She gets to do an in-service on a new electrical stimulation unit for just NMES.
Oh,
we have
cool.
one in the clinic she's just going to demonstrate and tell everybody how it works.
Yeah. Now here's the fun part, right? Because you brought up something a little fun. We don't have to dive into it. NMES. Because what is NMES?
What is it?
Yeah. I always struggle with it. I say neuroelectrical muscle stimulation.
Well, it would be if it was NEMS, but it's neuromuscular electrical stimulation. Yeah, exactly.
So my brain always messes that one up. Just if I'm being honest. So basically, you're putting the pads on the muscles and you're having a fire. So I think that's where my brain says neuroelectrical, but it's just neuromuscular stimulation.
Yeah. So,
but yeah, well, that's a good week.
Yeah, it was a good week. How was your week?
Yeah, my week was it was busy.
Uh-huh.
Had to. I got more personal injury types of cases this time, so they're fun and not fun.
Yeah.
And what I mean by that, when they're not fun, is we're dealing with like a car accident or just a slip and fall at specific locations or whatever like that I can't disclose because the case. And you're trying to treat someone through a traumatic injury, a traumatic event, and actual trauma. Right? So it's always a mixed bag, when they come in and present themselves, where it's fun to put on my thinking cap. But it's also not fun to ask someone, so how did this start? Because a lot of times it's in events where they didn't even want to be in by any chance. So it wasn't even like a sporting event where they were looking to get into, right? And then they just got hurt doing that. I was just on my way home and got hit by a car.
Mm-hmm. Yeah.
So those aren't always fun to start with, but I get to meet some interesting and cool people doing that too. So
awesome.
Had that going on. Lots of low backs this time. I hate to brush over a low back, like it's just a low back, but it's kind of in a chiropractor's bread and butter. Like if you're not good at treating low backs, what are you good at?
Yeah.
So yeah, it's been fun. Overall, had some really fun patients in terms of like rehab. They're asking good questions, like how much weight am I supposed to put on this when it was specified? I'm like, oh, that's a fantastic question.
Yeah.
And I tell them there's no right answer.
Yeah.
In terms of the number, but there's ways to figure that out. Well, we'll talk about that in a little bit.
Nice.
And some people that are just progressing with the treatment protocol. One side tangent on that one, if you guys want to know where my brain goes in terms of like what to do next, right?
Yeah.
Sometimes the answer is to not change anything.
Yeah.
It's working, so let's just stick with this for a little bit. And funny enough, that's been a lot of this week, as in treatment worked last time, rehab's working, I'm not going to change anything, we stay here.
Yeah, I had that come up as well, where a patient was like, a patient told me I'm really satisfied with kind of how my treatment's gone because he had a previous treatment at a different clinic with the same surgery, was a shoulder dislocation, and had surgery, went to treatment, they rehabbed him, and then he was better, and then he went and dislocated his shoulder again and had to have the same surgery. So he came to me because he grew up with my son playing baseball, and he had a specific protocol that the doctor gave us, and we kind of followed that. And it was thankfully his glove hand and not his throwing arm, so it wasn't too. We could start things a little bit earlier than normal.
That's good.
And he was just grateful for the fact that. He said that at the previous clinic he was at, they kind of jumped around and didn't really do things similar each time, so that he couldn't really tell, oh, okay, well, now my bicep curl I'm curling 12 pounds instead of 8 pounds, and now I'm doing a lateral deltoid raise with 15 pounds instead of 10 pounds, and I can do external rotation with the red band versus the yellow band. So he was really grateful for that. Part of that was definitely protocol based, but a lot of it was, most rotator cuff repairs respond to certain things, and those are the things that work, and so we stick with those. And it was nice to hear his feedback, because it just reminds me sometimes, like I don't know if you feel this way, but sometimes I'm kind of all over the place when it comes to exercise. And I appreciate what worked last time, but I want to like try something new or try something like out of the ordinary, or and so Protocol's nice because it can keep you in line and give you and make your thought process more streamlined, as well as provide that kind of bread and butter of, okay, these are the 4 things that we're going to focus on, and let's see how those progress.
Yeah.
And that gives us the benchmarks to progress them, like you said, with more weight. Are we going to add more weight? Yes, we can, but right now we want to do it incrementally.
Yeah,
and so
100%.
that was
Do it smart and do it right and appropriately.
And so I had that. I think I had a discussion with another PT, and they were saying that their patient appreciated that as well.
Yeah.
And it's nice to see, just to have a foundation of kind of, oh, now I'm better. I'm getting better. I can tell I'm getting better because now I can lift more weights with the same exercise that I've been doing.
Yeah, 100%. Yeah, I think especially in this day and age with social media and just being having access to so many things, it's easy to say like, this specific exercise, if you try it this time, is going to be best for you. And honestly, they can be right. However, if you have that one exercise just once versus the same exercise the same time for 4 weeks in a row with increasing reps or increasing weight, maybe the time, I wouldn't say maybe, more often than not, the time under tension with that many reps and that many sets and that specific way of doing one thing adds more change to what we need to do rather than just one new exercise one time.
Right.
So the novelty is cool, but it doesn't mean that the basics are bad.
Right.
By any means. Not at all. Yeah, it's we just want all the new stuff all the time.
Yeah, of course.
Which, I mean, I try new stuff all the time with my patients. They know, as in like, oh, let's try this exercise today. But I'll go back to, I know what works and stick with that. There's like a reason why knee extensions and knee flexion holds have been a part of like every single program since the beginning of time.
Yeah,
like they work. So
exactly.
Keep it with that. All right. I know that was a fun little side tangent there. I just remembered all that stuff happened with my patient here. But we were having this discussion off camera, and I was like, oh, this could be kind of fun. You brought it up with your first case and patient that you were talking about, where this patient technically, image-wise and diagnostically, looks okay, right?
Yeah.
Like if you were to see this patient on a piece of paper, you'd ask, why does this person have pain?
Yeah.
But they have pain. So is there is always a possibility of you having pain without actual quote-unquote found pathology at the time. Not every single ache or pain has to have a listed diagnosis to it.
Yeah.
I'll say this much, though. It's always better if we can go find one, because sometimes there is better protocol for everything.
Right.
But sometimes you just hurt.
Yeah. No, it's very true.
Sometimes you just hurt.
Very true.
Yeah, I think that's where we wanted to kind of like dive into those thought processes here. So like for you, you said this patient wasn't necessarily always painful unless she gets into deep knee flexion.
Correct.
Is that, yeah, you said that was correct there. Anything else that was painful for her?
I think that was the primary thing, and maybe a little bit of weight bearing on the knee if she was kneeling, well as. But I would say that it was primarily that deep knee flexion. She works in a lab in school, and periodically has to do things in that squatted position. But she's also a dancer, and so she does. She has a couple different styles of dance, but her primary style of dance is Bollywood.
Okay.
And she says that the strain of kind of just the repetition of her movements sometimes bothers her knee as well. So we wanted to experiment with. I wanted her to experiment with some practice this weekend to see if that would. Because the thing that I found that I introduced most recently was more of a capsular stretch with a towel in the back of her knee. Okay. So when she's doing that deep knee flexion, she's kind of stretching that capsule. That capsule.
It's a fun one.
And she's gotten a little bit of reduction with that. So that's kind of nice. But again, then there's always like, she kind of almost seemed like she had some anteversion in her hip on that side of the knee, always with a little bit of internal rotation all the time, and not that she was super tight in her external rotator or in her internal rotators, but maybe she was weakness. There was weakness that I didn't discover in her external rotators, or. I mean, I would target her glutes all the time in different ranges and different angles. With different loads, and she would get stronger. She's gotten stronger for sure. Yeah. Just for some reason just still has a little bit of that knee pain. So
has the pain gone down a little bit?
it has. Yeah, it's definitely like it used to be. She used to have pain pretty constantly at like a probably 5, 6, 7, and now literally she only has pain at that end range like a 1 or a 2.
Okay, yeah.
So I mean, there's definitely been some improvement, and we've discussed that as well. So
yeah, that's good. I think like talking about that improvement of like that 5 to 7 to occasional is actually a big win, especially if we're talking about like a plan of care, right? If someone comes and starts with a 5 to 7 pain out of 10, and now I'll just quantify it as a 1, like she only feels it at that specific moment, right? But it is painful at that point. That's nothing for them to like to shy away from. That's something to celebrate.
Sure.
I was like, yeah, you went from I can barely like do this and start with this to I can do this, and it's not really painful unless I do certain things. So the way the body changes, I wish it was just like overnight. You fix it,
right?
Fix that one mechanic right then and there, and then no pain.
And then boom.
Our entire business model would be 100% different if that was the case.
It totally would be.
But it's not, right? So yeah, it's always fun to kind of dive down like that because like, there's technically no quote unquote meniscus tear, even though it could.
She had an MRI. MRI was negative for meniscus tear, and she didn't have any arthritic issues. She did have some tenderness with her pes and her
pes anserine.
Pes anserine. And I've noticed in my years of practice that when someone has weak quad muscles, that their pes tendon tends to take the brunt of the load, and so they get some tendonitis in there. So we found that some of the taping helped. With the kinesiology taping, that helped a little bit to support her when she was moving and doing her recreational stuff. But again, I want to see kind of how all that works when she dances.
Yeah, 100%. I think one thing that I always think about, because a lot of times it's easy to kind of say that's an overuse injury. But what's funny is that if we treat an overuse injury with just exercise, technically you're using it more, but it feels better. So is it overuse? My brain tends to go off of, if it's something like that, it's underprepared. So there's there's certain weaknesses in certain things that cause that tissue tolerance to not be there. So I like how you said, you've been treating her hip for knee pain, and I know a lot of you guys out there are like, oh, why don't you just go straight for the knee? Which we still do, but the best way I've tried to describe it to patients is when we look at the lower extremity. Right? You could technically put this entire thing to like any limb, but it's always kind of fun to just single it out for that. For the lower extremity, I often think of it as like Indiana Jones's bullwhip, as in
I like that.
The effect of where you feel it is at the end of the whip,
right?
But where we start all the process is
at
the handle.
At the handle, yeah.
Which really, if you think about it, is where our shoulders and where our hips start. So if we don't address that part, sometimes it's that end, or sometimes it's something else.
Right.
But if we look at the muscles and how everything is formed biomechanically, hips have some big muscles.
Yeah.
Knee, it has some big muscles, but the hips for sure have larger muscles that control everything else.
Yeah.
And they control positioning, they control power. So let's also focus there.
Yeah.
We're never not going to touch the knee. Don't get us wrong.
Right, exactly.
But if we just focus on the knee and not focus on you as the whole person, especially when it's pain without like a true pathology in that one area, then we might be missing a bunch of stuff. So I know I kind of went on that little side tangent there, but it's been fun. This is
good.
But that you said a capsular stretch has helped.
Yeah, definitely. And we did check a little bit of her. I've had some success as well when there's been some knee pain. And the knee pain for her was interesting too, because it almost felt like it was a little bit ligamentous in the sense of like her MPFL, her medial patella femoral ligament.
Ooh.
I know, right?
Smart.
That is
smart words.
That is a mouthful.
Yeah, that's honestly that's why we abbreviate so many.
Yeah, exactly. I know, right? ATFL.
Yeah, and then here I am struggling with NMS. Sorry about that.
That was good. I like that. But yeah, it was tender along her medial patellar border, kind of along the femoral condyle, kind of where all that stuff attaches, and even so, like, I mean, I think ultimately it goes back to some of her biomechanics and kind of how she's always standing and how she's moving when she moves and all that stuff that kind of plays into it.
And correct me if I'm wrong. You said chemical engineer?
Chemical engineer, yeah.
She's studying to be that, or she is?
She's studying to be that.
So, I mean, we've talked to engineers before. It's like, yeah, they could be behind a computer for 8 hours and not realize it.
Yeah, no, very much so. She's there, very much of a sitter, and then she sits in a lab where she does analysis there as well. So, and then she has to walk up and down the hills of her campus, and occasionally in the lab, she's doing some stuff in that deep knee squat, which she has a great squat. She's got great mobility. It just, there's always kind of a little bit of that. Well, what is it really? Is there something just kind of tweaking a little bit more at the end there?
Potentially,
right?
yeah. It's not that it doesn't, right?
Right.
It can. You could also have people that have that type of presentation and have zero pain.
Yeah, exactly, right? Which is kind of where we go back to that idea of, does the X-ray or the MRI really distinguish or interpret what's going on, or is it just that's them?
Yeah. So before we go on to that thought, right?
Yeah.
Actually, to lead into that thought more, what would you say to a patient that says, hey, I'd like to get treatment, but I'd love to see what the X-ray or MRI says?
I don't mind that.
Yeah.
I think that, more knowledge is better.
Yeah.
But I would also, give them kind of not necessarily the warning, but just the caveat that what we see there is kind of a snapshot, and based on kind of how they're presenting may not be what we're gonna see. In the sense of X-ray is primarily a bony reveal versus an MRI, which is more soft tissue.
Yeah.
And so, like when I got my hip X-rayed, when I had hip pain before I had my left hip replaced, I was hoping that it was like an impingement or something like that. And the doctor came in and said, well, there's not a lot of diagnosing I got to do now that you've got severe arthritis.
Yep.
So in that case,
so you for sure had all the impingement. All of the impingement was severe arthritis.
In that case, then it's clear, right? Then the diagnosis is clear through the image. But yeah, I'll give them the warning or the idea that this may give us, it will give us information, but it may not be the information that you're looking for. Which it may not be the information that I'm looking for. It may not give us really anything, and it could reveal something that we don't even know is there.
Yeah, 100%. Yeah, for the images and X-rays, right? I'm not opposed to them by any means. People always wonder why I'm like so aggressive with just starting treatment per se, rather than just wait for the image, is mainly because when we talk about the image, the question really becomes like, what are we intending to do with the image? So once we get it, what are we doing next, right? Because I could probably tell you with some certainty, based off some orthopedic exams and some neurological exams, and I'll give myself, I'll be kind, right? I won't say 100%, but I'll be like within like 80 to 85%. I can roughly say it might be that. More likely than not, it could be that. It could be a disc. It could be nerve, whatever you want to call it there. What are we looking for with the image in terms of treatment protocol? Because oftentimes when we have the image, especially if it's like nerve-related thing, the bigger question is this a surgical case? Or is this something that we have to repair? Like for your hip, you're checking like, is it impingement? Hopefully it's just that. And if not, you got to replace that bad boy, right? So,
and like you're saying too, with like a nerve issue, like maybe a disc issue with an MRI, there's been studies that have said that if we MRI'd 75% of the population, we'd all have some asymptomatic disc bulges that if we're not really necessarily feeling it, doesn't mean it's not there. Yeah. And if it is there, do we need to treat that specifically just because it is there? Yeah. I think that's a huge eye opener in the sense of, if we told all of our patients that, they'd be like, no way. Yeah. If you I know if I got an MRI of my spine right now, I would definitely have a disc bulge.
Yeah. I know for me, as a fact,
Yeah.
probably would. I mean,
Yeah.
you've seen me squat.
Yep.
It's
Yep.
not light. There's extra stuff on there.
Yeah.
You've seen me
Yeah.
pull some weight in here.
Yeah.
Yeah, I probably have something going on.
Yeah.
Because like sometimes I'll wake up, I feel a little twinge left side, and it's always my left side. I'm like, there might be something there. There might be something there.
Yeah.
I wouldn't be surprised. But at the same time, right, if pain isn't always there, and I'm not limited to things that I'm able to do without complete like debilitation where like, hey, I can't move my leg.
Right.
Or I can't feel the side of my knee, or I can't lift this leg over this ledge, or I've noticed that that's getting worse.
Yeah.
Then do I need surgery? Probably not.
I have another good case about that too.
Cool. Yeah, let's go off that. I know we're kind of going off the rails, but this is kind of fun.
Another patient that I have, she came in with she was shifted to the side, like a torso shift, and had a little bit of radiating pain down her leg, and in her, I guess, in her prescription, it said that she had a congenital pars fracture.
Oh.
Which to me means that she theoretically should have some anterior slippage of her vertebrae. And as we treat, again, this was like she didn't have any imaging at that point. And so me treating as I treated kind of the shift to try to get that out, and then kind of feel around and see how her mobility and her joints felt. She didn't feel overly hypermobile in her lower lumbar. I did a little bit of just light soft tissue and a little bit of just light joint mobilization above that level. And then finally, as she progressed, she got a little better. She got a little better. She got a little better with movement, with nerve glides and things like that. A little bit more stabilization for her lumbar spine. A little bit more kind of gapping to try to stabilize that. Had her get an X-ray, and the X-ray came back and said that were no bony osseous changes in her lumbar spine, which I thought, okay.
Yeah. It's weird.
If you have a pars fracture that's supposed to be there since you were born, I wonder if it's just healed itself.
Potential.
Yeah, right. And she had it was an X-ray. I don't know if she had an MRI, but
yeah.
So another instance in that sense of kind of and she's responded really well to everything that I've done. I mean, so much so now we're now doing. She's kind of returned to doing her exercise, her Pilates tapes at home.
Yeah.
She hasn't gone back to a class yet. She's now able to lift her two children. She's got two small children,
fantastic.
A 5-year-old and a 2-year-old, and she doesn't have pain anymore.
That's fantastic.
Yeah, it was awesome.
Yeah, and I think, and I say this with all respect too, before I go down this road, because I realize this could be taken the wrong way, is that me as a chiro and me as a person that treats, oftentimes we can still be wrong about our diagnosis, right?
Oh yeah, most definitely.
And hence why it could be a working diagnosis. Hey, Aurora.
And there she is.
There's Aurora.
Hey, Aurora.
But yeah, it could be a working diagnosis, right? So at the time, that's the diagnosis that we're working with.
Right.
At the same time, the radiologist that has never seen you, or it just sees your image and reads what it says and makes their diagnosis off it, can also be wrong.
Yeah.
So
yeah.
I'm not saying that in this case that person was wrong to say that there was a congenital pars fracture or wasn't a congenital pars fracture, but we have on our end the human element. Yeah. And I'm the first one to say that I definitely have missed or not caught other things until someone else saw it. And that's where we work together on a lot of stuff.
Yeah, definitely.
But yeah, that's not to put anyone down. It's just saying like, hey, I've done it. So
no, most definitely. And it's interesting too that you know, halfway through her treatment, realizing, okay, I need to explain to her what it is, and then as I'm explaining to her, I'm like, okay, theoretically, I shouldn't be doing joint mobilization because we don't want to increase that instability. But on the other side, the joint mobilization I was doing was benefiting her and providing relief and giving her the mobility and the functionality that she needed.
Yeah.
So I think that's another kind of idea of treating with just what the patient presents, how the patient presents to us, and how the patient responds to how we treat based on kind of the diagnosis and or
100%.
the response, I guess. I don't know, the pathology. I don't know.
I can see where you're going with it.
Yeah.
So hopefully you guys track with that. But yeah, a lot of times, like, you'll see the patient and be like, yeah, this guy's broken because
Yeah.
I have so many things.
Yeah.
And technically on the diagnosis list, you don't know where to start.
Yeah.
Right? I'm not saying that there's no pathology in there, but
Right.
sometimes the way that they present plus the diagnosis that's technically written out don't necessarily always line up.
Yeah. And that was, I think, the case too. It was very interesting. It was
And that's why we call it the working diagnosis, because it
Yeah.
could change.
yeah, it can.
Yeah.
But yeah, no, I've given her the, the education of how to stabilize that if there is some instability with her pars fracture. And I mean, seeing on a piece of paper to tell me that there was no changes, which is, I think, really good, still gives me that idea of, okay, somebody said it was here, somebody's telling me it's not. I'm going to go kind of err on the side of caution and, conservativeness in regards to giving her that idea of it may not be there, but it also still could be. So these are the things that you need to do to help to stabilize,
Yeah, obviously we want to make sure we're not pushing them to something that they shouldn't be doing.
Yeah.
That could be detrimental to their health.
That's definitely always my fear.
So yeah, there's nothing wrong with going a little conservative
Yeah.
on that treatment, or conservative on how aggressive we go on certain things, right? That's completely fine. So that's one instance where the pathology doesn't match the pain.
Yeah, at all.
There's also like your first patient where it's
Yeah.
like technically no pathology.
Yeah.
By technicality, you could argue all the stuff that we argued before, but it could just be weakness.
Yeah.
As in, like, the tissue is not ready to go from being a chemical engineer and you're sitting down and squatting and just being in certain positions for a long time to now going to dance.
Yeah.
When you go to dance, there's so much force that can go through the knee,
Yeah.
right? So you go from not training it or putting in positions to be trained in that with that much stress to we're putting a ton of stress on it right now.
Yeah.
That could be part of the pain. That's oftentimes what it is, especially like I often see with runners. Runners that don't want to do any version of weightlifting.
Right.
As in, feel good until about 3 miles and then the pain comes.
Yeah.
And it always happens at 3 miles. So is it a cardio issue or is it the tissues just can't handle 3 miles?
Oh, yeah. Definitely.
Tissues can't handle 3 miles
Yeah,
more
for
often
sure.
than not. And then to put it on its head, sometimes with my my strength athletes, my powerlifters, my Olympic weightlifters, maybe we got to work on some cardio. Yeah, because your body can't recover in between sets.
Yeah.
And you're trying to push really hard
That
right
makes
now.
sense too, yeah.
So, yeah, oftentimes, do we need the diagnosis? I think it's fantastic if
Yep.
we do.
Yep.
I'm not saying we don't need the diagnosis. But sometimes we just continue forward until we get a better one.
Yeah, exactly.
That's what we're doing.
Yeah. I like that idea of that working diagnosis because it could change for sure.
100% could
Based
change.
on kind of how things develop through treatment with increasing strength, increasing range of motion, increasing kind of just alignment through biomechanics and stuff like that. So
Yeah.
that's...
Because even, I know I've mentioned this multiple times. You've heard the story at this point multiple times. Like, my knee did not show up as a traditional ACL tear.
Right.
There was no swelling. There was no throbbing. It wasn't purple. And I was walking around on it 2 weeks later, right? Did not present as, popped. You heard a pop. You stepped, pivoted, and turned, and you felt the throbbing in the knee, and it was all purple within an hour, right? That was not my knee. But did it mean that we stop everything? No.
No.
Yeah,
Right.
That day I was 2 nights ago, basically pretty close to right off the bat.
Yep.
Started heel slides.
Yeah.
Started doing what my body would let me do.
Well, yeah, and that's I see that.
Yeah. But yeah, so we're not scared. Is basically to start treatment, but we'll always pivot if we have to.
Yeah.
Because the last thing we want you to do is just be so fearful of motion.
Yeah, that's true. No, we definitely don't want that old school thought of let's cast it and keep it from moving.
Now, granted, if if this is broken and surgically we had to put it
Yeah,
together,
I
maybe
mean,
we will have to.
There's a little bit of that, but I mean,
Yeah.
I think ultimately, if like you said, that you're able to move and put weight on it, and it feels semi-stable, you know,
And then we're gonna move a little bit.
then we're going to start to move you.
Yeah, 100%, 100%. So
Obviously, using, I think, you know, just the feedback that the patient gives us during that movement and that observation, you know, will modify. But yeah, definitely.
Yeah. So like I think half of like my job, I would even say more than half of my job, like 75% of my job is giving a lot of patients some permission that they're okay.
Yeah, I can see that for sure.
Yeah. Because like, I mean, we're not, for the most part, we're not mostly like not in network, but we're also not in network. We're also out of network, but we're not just right post-op. We're not pre-op where something is broken and we're trying to keep some movement going. And then, we go in with that. And a lot of times we've seen patients after they've seen other PTs, other chiros, and it's been some time and they have this pain.
Mm-hmm.
Yeah. For most stuff, you're probably going to be structurally okay 4 to 6 weeks after a minor thing.
Yeah.
Maybe a couple months for like a big tear, right? You should be okay structurally, but we got to work on everything else.
Yeah,
And
for sure.
That's usually where we jump in. Yeah. All right. Anything you want to add to that?
No, I think that's good.
Yeah.
Yeah.
I really don't have anything else much to add other than like, I think it's okay to get started earlier than you think.
Yeah, I think that's the truth.
Yeah.
And like you said, just I think, you know, following. I think the other thing I would say too is just kind of listening to your body.
Yeah.
That's been the biggest.
Yeah.
You know, when, like I was talking to a patient this morning, pain. You know, the old adage of no pain, no gain. Within reason, right? Yes, we want to list. We don't want pain that makes us feel like, God, that doesn't feel right.
Yeah.
But the pain of like a fatigued muscle that's burning because it's fatigued, I think it's okay to push through that. And I think that pain is, you know, quote unquote, maybe good pain. But you definitely want to listen. I think listening to your body, and even as a practitioner, listening to your patient. I think that was one of the things that I really identified early in my career was when I listened to my patients, everything got a little bit smoother and went a little bit easier and kind of directed me in the way I felt like I knew I wanted to go.
Yeah.
But giving the permission, you know, them saying, okay, well, this is what it felt like when I did this, and this is what it felt like when we did that, and that would trigger where I needed to go next.
Yeah.
And that really made a lot of difference for me, and that's one thing I always kind of talk about. But then the other thing definitely is just got to listen to your body. And
Yeah, 100%. I think Alvin actually breaks it down the best that I've heard. I actually steal his lines whenever we talk about that.
What's that?
Just to like reiterate what you're saying is that, we have to learn how to listen to our bodies. And the obvious question, if you're like me, is like, how? How? Like, what is good, what is bad, right?
What does that mean?
Yeah, because like, to be as an athlete.
Is my elbow telling me, hey,
like,
shoulders,
does it talk?
don't do that?
And I know I said I had nothing to add, but you brought up a great point. So here we go, right? Like you said, your elbow won't say like, hey, maybe we don't do this today, right?
Yeah.
But easy ways to kind of evaluate where you are, and this is a golden nugget for you guys because I actually tell this to a lot of my patients because of Alvin, so thank you, Alvin, is that you have to give yourself a green light, yellow light, and red light.
Ooh, okay. Yeah.
And by that, if there is 0 pain, maybe like a 1 out of 10 pain, where it's like, oh, it was uncomfortable to start, but it's not bad, then you're fine. Don't worry about it.
That's a green light?
That's a green light.
Okay.
If this really hurts, as in you start and this really hurts, that's a red light.
Okay.
But if it's something that stays this consistent amount of pain and doesn't increase, but it's not past like a 2 or 3,
yeah, that's a yellow light.
So I'm not saying that you
that
won't.
doesn't mean speed up.
It could mean speed up, but it also more than often than not it says it could become a red light.
Slow down.
So slow down.
Get ready for the red light.
But you could
like that.
Yeah, technically you can keep going. I think he says flags. My brain says light.
Yeah,
so,
no, that's fine. Yeah.
But it could be that.
Yeah,
as in,
definitely.
I know for when I hurt my knee the second time and you saw it and I had you evaluate it, right? And we figured out what it was. Yeah, I was putting load on it for sure.
Yeah.
I definitely was putting load on it. But there was definitely some emotions where I'm like, ow, I can't move with, well, I could move with this, but it's getting worse.
Yes.
Drop the weight.
There it is.
And I kept going, and I was fine. So in some ways, you kind of have to ask yourself that question. We give you a little bit more practical stuff to do when that happens here. I can't give you all the magic, guys.
And I think along that same kind of green light, yellow light, red light, my favorite saying is, if you feel like it doesn't seem like that's what you should be doing,
don't do it.
Don't do it.
100%.
Yeah, because I've had that with myself where I'm like, that just doesn't feel right, and then I stop, and I'm better for it in the long run. And that's like one of the things that's kind of almost the hardest thing to kind of get across to patients is that, and just to anybody that. But you said it would help. Okay, yes, I did. But
with asterisks,
obviously, if you're hurting, like even in treatment, if we're treating somebody and they're sitting there not breathing and clenching their jaw and clenching their fists, how does it feel? Fine.
It doesn't feel
Feels
fine.
great.
It's not feel fine.
Okay.
It feels great.
Yeah. You know, that's no, you're guarding and you're defeating the whole purpose of why you're here.
Yeah.
And so that feedback is something we got to listen to. And yeah, I always say if it doesn't seem like if that doesn't feel right, probably isn't. So let's stop that and kind of take it in a different direction.
That is 100% fair.
Yeah,
right?
that's the thing that's kind of my green light, yellow light, red light thing.
I actually like that part of the protocol with that. I think I've said similar versions to that for my patients.
Yeah.
The thing is, I hate saying that I only tell that to about 80% of my patients because I know 20% of you, if it's a 9 out of 10, you think it's fine because it's not a 10 out of 10.
It's not a 10 out of 10. I love the patients who sit on the table and say, and I say, hey, what's your pain? Oh, it's about a 9.
And they're relaxing there.
Yeah. Feels about a 9 right
That's
now.
not a 9.
That's not a 9. No.
Yep. A 9 is, you're screaming and writhing on this table.
A 9 is you cannot sit still. You are approaching tears, and you'd rather be somewhere else other than on my table.
100%. 100%. There's only ever been one time where I truly believed that from one patient, just because, it's within personal injury, so there's a lot of nuances that go on with that. But
that's
so
not a 9.
80% of my patients I will trust. The 20% of you that I know, I don't even bring that up because I already know you guys. As in, I can move this, but I definitely just got surgery, so let's go PR's bench press. Like, you probably not. Probably no.
Nope.
But it's okay. I understand that mindset because honestly, I'm one of those. So because of that, I don't tell 20% of those patients. So if you're wondering if you're that 20%, and if you haven't heard it, it's probably because you are that 20%. But it's okay. I love you guys. We could obviously dive into a lot more other stuff on this one, but I think that's the premise of it is not every single pain has to have a diagnosis, but it doesn't mean that we don't treat.
Right.
We treat and then we pivot.
Yeah.
And I think that's just a sign of a good, healthy place to be at.
Yeah, for sure.
Whether you come see us, which if you want to see us, we take new patients all the time.
All the time.
We'd love to see you guys.
Yeah, SHARC.com.
Let's say you're out of state and you're finding someone else. That's kind of how you evaluate them. Are they willing to pivot if something isn't going the way it should be going for your own benefit?
And are they willing to listen to you? Are they willing to hear what you have to say versus watching you do something and telling you exactly what it is based on that, which may not be wrong, but, if they're disregarding what your input is, you are the consumer and you have the ability to get a second opinion.
Yeah, that's
I've
fair.
told my patients that many times.
Yeah.
That's the beauty of being the consumer.
100%.
Doesn't mean that the patient's always right, but it means you have choices, and we hope that you choose us. But it's always good to get a second opinion.
So the answer is, it depends.
It
I know you hate that answer.
depends. Sorry.
But yeah, obviously we can always dive into other stuff like biopsych. We don't really have to get to that. That gets really complicated really fast.
Yeah, definitely.
Mainly, you are more complicated than you realize, and we love that.
Yeah, we do.
But yeah, sometimes that pain without that pathology could be that It could literally just be you're not ready to go do that motion yet.
Yeah.
Or it could be it's something else that we didn't consider.
Yeah. The tissues are not ready for that. I like that.
Yeah, underprepared.
Yeah, underprepared tissues.
Underprepared. I've been using that a lot more. Or look at me teaching some stuff. This is wild.
Awesome.
All right. Anything you feel like we have to add?
No, I'm good.
No, fun.
Good.
There's a fun thing that I wanted to add. I gave him a baseball card, which was kind of fun. And I'll say this: I'm a Dodgers fan, so I didn't want it. Anyways, it was a Giants. Rafael Devers.
Rafael Devers, baby.
I like him as a player. Too bad he's a Giant, but whatever.
Yeah.
Anyways,
good. Appreciate that.
No
one.
problem. You could actually thank Alvin for that one.
I will for sure.
So it's all coming full circle. One of these days we'll get.
As soon as that Arise card comes up too, I'll take that one.
there you go.
There you go.
Yeah. So one of these days we'll get Doc T into it. He probably won't, but we'll try. We will try. All right. But yeah, I think that's where we'll wrap up here. So I'm Dr. David Johnson.
Yeah. PT Non-D.
And this is SHARC Doc Talk. See you next time.
See ya.